mul- involving multimodal brain imaging, neuroimmunology, and neurometabolism. He leads a specialized clinical research service for schizophrenia, individualized schizophrenic treatment and reintegration INSTAR program at NIMHANS. Yet another area of his interest involves neuromodulatory interventions in psychiatry. He leads the weak intensity stimulation for enhancement and reintegration. WISER neuromodulation program at NIMHANS, which implements clinical and neurobiological research studies in transcranial electrical stimulation techniques in psychiatry. Dr. Venkat Subramanian's research works have led to more than 475 research publications and have been recognized with several awards. He is an elected fellow of the National Science Academies as well as the National Academy of Medical Sciences of India. The Council of Scientific and Industrial Research, the apex agency of the Government of India for Scientific Research, awarded him the prestigious Shanti Swarup Bhatnagar Prize for Science and Technology, one of the highest Indian science awards for his contributions to medical sciences in 2018. We are very fortunate to have Dr. Venkat Subramanian with us, who is a pioneer in the field of biological psychiatry, especially schizophrenia. I request Dr. Venkat to enlighten us on the subject. Dr. Venkat.
Yeah, yes, sir. I'll just share my screen. Yeah, yes. My screen is visible, sir?
Yes.
Yeah, right. So good evening, all. It is my honor and privilege to be amidst so many stalwarts, several of the teachers here, and I place my sincere thanks for this invitation. Dr. GVS Murthy, Dr. IVL, and Dr. Sarat Chandra, and several of the other colleagues, teachers, friends, and students. So I hope to selectively focus on certain aspects of schizophrenia with more emphasis on some of the emerging and practicing consensus. And I hope to learn through the interaction in the next 1 hour or so. Schizophrenia, as we all know, is a complex multifactorial clinical disorder, and it is characterized by wide varying phenotypic presentation. And the current consensus is multiple genes of different combination, which is also called as a polygenic nature, interacts with several environmental factors that leads to the genesis of schizophrenia. So this particular slide gives a summary of the onset, progression, and the course of schizophrenia, emphasizing the importance of genetic contribution, which is mentioned as a genetic load here on this corner, which this genetic load interacts with several environmental stressors. Usually, this kind of interaction adversely impact the brain development, leading to the onset of first episode of psychosis, and then the disorder takes a waxing and waning course. There are also a lot of neurobiological research findings which implicate brain formation related abnormalities starting from neurogenesis, as well as brain reorganization abnormalities, which involves myelinization or arborization of the dendrites and so on and so forth, which can be mapped to the clinical course that I depicted in the previous slide. What is important, especially with more and more recent research, findings suggest is that the early course, especially the prodrome to the onset of first episode and in the early period of this disorder, perhaps is the window of opportunity during which one can initiate several effective interventions that can potentially change the course of this disorder. Now, I just want to emphasize on one recently emerging bedside research theory, which is influencing the understanding of schizophrenia. It goes by the name of predictive processing. I'll just spend briefly the initial few slides on this theoretical advance, and then I'll go on to some of the treatment-related fundamental principles and current trends. So introducing predictive processing, if I have to summarize it, we can mention something like we see what we expect and we expect what we see. Now let me give an example. In this particular slide on the left-hand side, there is a shadow. If I am asked a question, what do I see? I may kind of think and guess, and based on my previous experiences, I may say this shadow might probably be due to that of a dog. Here, this kind of prediction is also called as Bayesian processes, where the incoming information is processed in the light of the prior expectation. That is, my past experience makes me to guess what is the likely cause of this particular shadow. And this kind of processing of the incoming information in the light of the prior expectation and belief is called predictive coding. Now, with respect to schizophrenia, there is a lot of research advances, especially in the past decade, that has linked the various pathogenetic processes with what is called as an aberrant predictive brain. Let me extend that example. Suppose if I am asked to look again, and now as we see here in this slide, especially on the right-hand side of the box, the right-hand box, we see an unusual situation where the shadow of the dog might have been caused by a cat. Now, I'm getting a sensory information that does not match with what I expected. So this kind of mismatch is called prediction error. Now, I may choose to update my prediction and correct it and say that, yeah, maybe this is an unusual instance where a cat is creating an image that looks like that of a dog. So this is something which happens usually. On the other hand, if the predictive processes are deranged, my brain will choose to retain my earlier model and will refuse to change. And I may say that in the context of a schizophrenia kind of experience, I may say that maybe this is something which is purposefully planted by my persecutor, so that the persecutor wants me to say that I am not even capable of differentiating what is a dog image versus what is a cat's image. So this kind of imbalance in the prediction system can lead to faulty inferences, which can cause delusions, or false perception, which can manifest in the form of hallucination. What is interesting and important is that all these aberrant prediction processes are linked with glutamatergic, dopaminergic, and GABAergic abnormalities. And there are many other theories which are linked to this kind of predictive processing deficit in the schizophrenia, through which other symptoms like negative symptoms as well as the cognitive deficits could be explained. So essentially, these kind of cognitive theoretical models, which are based on some of the neurobiological advances in the recent time, helps us to link some of these processes with certain neurotransmitter abnormalities. And the most important of it from the clinical perspectives is the dopamine. And if we look at some of the brain imaging correlates, there is a prediction network in the brain which is shown to involve various brain regions like prefrontal cortex, temporoparietal junction, insula, striatum, hippocampus, and cerebellum. Many years before, we did a study at NIMHANS where we reported deficits in most of these brain regions. Most of the brain regions that are listed in this prediction network in people with untreated schizophrenia who presented to the hospital for the first time. So essentially, These findings, as well as several other research observations, support that schizophrenia has brain deficits that involve prediction network. And through these kinds of recent neurobiological advances, we can link it with some of the brain electrophysiological deficits and so on and so forth, through which we can understand several of the symptom manifestations of schizophrenia as aberrations in perception, cognition, and action. All these are linked with predictive abnormalities. Very recently, we were able to report some of the functional MRI findings, which are also along the lines of the prediction network deficits. So essentially, I just wanted to highlight one of the important recent neurobiological development of the predictive brain abnormality and its brain deficit and network aberrations in schizophrenia, which can be linked with certain specific neurotransmitters like glutamate, GABA, and importantly, dopamine. And this is the summary of the evolving neurotransmitter aberrations that are implicated in schizophrenia. It is shown that the glutamatergic receptors in the GABA neurons are deficient, due to which the cortical glutamate gets into a hyperdrive mode. So essentially, this kind of hyperactive glutamatergic deficit in turn drives the lower order or the further lower down in the network certain neurons, which basically lead to hyperdopaminergic situation in the mesolimbic system, which leads to the positive symptom, as well as hypodopaminergic status in the mesocortical system, which leads to the negative as well as the cognitive deficits. And all these glutamatergic, GABAergic, and dopaminergic abnormalities can be again linked with the predictive processing. Now, let me I just wanted to give a summary of this and illustrate some of the theoretical advances that are happening. And it is very important to note that these theoretical advances again emphasize the centrality of dopamine, and which is basically the key neurotransmitter through which several of the antipsychotics function and ameliorate the symptoms in schizophrenia. In the remaining part of my presentation, I'll be just touching upon some of the fundamental principles and then highlight some of the recent consensus in our approach. And then during the discussion, we will have more interactions, and I'm looking forward to learn through all our experiences. So one of the important consensus that has emerged is the so-called differences between the first versus second generation antipsychotic status-wise. This is an important publication that was that appeared many years before. But the summary statement of this publication is that if extrapyramidal symptoms could be minimized by careful dosing and anticholinergic use is avoided, there has been no convincing evidence to support any efficacy advantage of second generation over the first generation antipsychotics. But nonetheless, if you look at our practice, we have been inclined to prescribe the newer antipsychotics more often than the older, mainly because of the differences in the gap between the therapeutic effect and side effect. So especially it is, if you look at an older molecule like haloperidol, it has a very narrow therapeutic index. Sometimes it could be as small as 0.5 milligram. Whereas if you look at the molecule, say for instance, olanzapine, the index is very wide. So we are more comfortable in prescribing mainly because of its the broader or the wider therapeutic index. The second important reason why we have perhaps shifted to the newer antipsychotics is the risk for tardive dyskinesia with the newer molecules is much lesser than what used to happen with the older molecules. Now, Within these antipsychotics, there is also another divergent line of evidence which basically influences our psychopharmacology of schizophrenia, which is more of a mixture of an art and science. The one of the central such question is whether all antipsychotics are very equal in its efficacy. There are several nice summaries that have evolved in this line, and this is one important paper that has compared 32 oral antipsychotic using a systematic review and network meta-analysis. And basically, the findings suggest there are certain molecules which are likely to be more efficacious for the primary outcome in each of these studies. So some of these molecules involve clozapine, amisulpride, olanzapine, and risperidone. And we know from our clinical practice, we tend to prescribe these molecules more often than others. If you look at the overall change in symptoms, this is the order of efficacy rating, with clozapine being the best of the 5. Then we have amisulpride. Zotapine is not so much in use now, and we have olanzapine and risperidone. With respect to negative symptoms, the role for amisulpride is perhaps a more preferred agent. And depressive symptom-wise, again, molecules like amisulpride, olanzapine, and aripiprazole, they score a bigger plus than most other molecules. Of course, clozapine in the context of people that have treatment-resistant schizophrenia. The other important consensus that has emerged is with respect to the QTc prolongation. This is one area where more and more research suggests with amisulpride, we have to be a little bit more careful, whereas molecules like aripiprazole and lurasidone are much safer. The second important dogma that has been challenged is the notion about the onset of antipsychotic action. The traditional thinking is that we need to wait at least for about 6 to 12 weeks to see visible effects of antipsychotic benefits. So this used to be called as a delayed onset of action hypothesis. In the sense, the meaningful effect may happen after about 4 to 6 weeks, whereas to see any discernible effect in the clinical picture, we need to wait at least for about 2 to 3 weeks. That is the classical teaching. On the other hand, the more recent proposal is that of an early onset hypothesis, where as early as within the first few days or within the first few weeks, one would expect to see noteworthy change in the clinical picture. So which indeed was demonstrated in several studies, which is summarized here, where the significant clinical improvement in terms of the global clinical benefit happened within the first week. And as we see here, the percentage change of the clinical symptom is maximum in week 1 in comparison to the subsequent 3 weeks. There are also studies that have kind of summarized it, which essentially confirmed the early onset hypothesis of antipsychotic medication. So this particular slide I want to summarize and show that the improvement that happens in week 1 is much, much more than the rest of the entire 1 year, in terms of looking at the data over the first year of treatment with antipsychotics. Now, this early onset hypothesis and its increasing support has led to some of the guidelines to reduce the period of adequate trial with antipsychotic in the sense like how much time we can wait before switching to a second molecule. With respect to the maintenance phase treatment, for maintenance therapy, there is a recommendation that antipsychotic dose should be reduced gradually to the lowest possible effective dose. But the rule of the thumb is the target should not be lower than half of the effective dose during the acute phase. So that is the consensus recommendation after reviewing a lot of studies, which is given by the Takeuchi and colleagues. And at NIMHANS, my colleague, Dr. Vijay Kumar, who did work on what is the antipsychotic maintenance dose in the treatment of schizophrenia. And he observed that the mean antipsychotic dose used during maintenance treatment was approximately 30% lower than the dose used during the acute phase. What was very interesting to note is about 40% of the patients maintained well with a dose that is lesser than the recommended therapeutic range. So this is an important observation because more and more recent research suggests once we reach remission of symptoms in schizophrenia, and especially in patients who need continued antipsychotic treatment, the dose requirement perhaps is much lesser than what has been examined in many of the earlier studies. Now, in the context of treating people with schizophrenia, the situation in which we need to look at long-term treatment will be patients where there is a persistent risk for aggression or suicide, relapse happening even with a minimal dose reduction, persisting residual symptoms, and also certain individualized or individual specific factors like what is the cost of the relapse. If the relapse is associated with significant adverse impact, where such a situation is unthinkable, then perhaps we need to look at a long-term treatment. So summarizing some of the emerging consensus, this is as per one of the recent guidelines. If we look at the treatment for schizophrenia in the context of first episode, in people that are having symptoms remission, and especially in people where none of these risk factors like aggression, so on and so forth are not present, perhaps after 1 to 2 years of symptom remission, we can think of stopping antipsychotics. On the other hand, in multi-episode schizophrenia, one may have to wait for anywhere between 3 to 5 years. And in the context of such broad recommendation, we have to individualize our approach towards continuing or stopping antipsychotics, especially by considering a host of factors like what is the nature of the adverse effect and what was the pattern of the illness, especially the speed of onset and the duration on severity, as well as the risk of severe symptoms, and especially some of the important factors like whether a dosage reduction has been attempted earlier. And if such a dosage reduction, sometimes in certain patient, even a reduction of say 1 milligram equivalent of say a medication like risperidone might have caused worsening of symptoms. So we need to individualize the course of treatment as well as the dose of the medication. Now, when we choose to stop antipsychotics, the guidelines suggest that we have to be extremely gradual and very careful and reduce and withdraw the antipsychotics under close monitoring. Abrupt withdrawal of oral medication may lead to discontinuation symptoms. There are research evidence that suggests the relapse rate in the first 6 months after abrupt withdrawal is double than that seen after a gradual withdrawal. So the rule of thumb is a gradual withdrawal is something like a 25% dose reduction every 4 to 8 weeks. So this is some of the consensus and the current approaches in first episode on treatment responding schizophrenia. On the other hand, if we come to treatment resistant schizophrenia, we are all aware about 1/3 of schizophrenia patients do not respond adequately to antipsychotic treatment. Importantly, treatment resistance in schizophrenia contributes to as much as 80% of the healthcare cost burden in this disorder. Now, there are several guidelines towards defining treatment-resistant schizophrenia, primarily initiated by Dr. Kane and colleagues. One of the recent development in the definition of treatment-resistant schizophrenia is what is called as TRIP, or Treatment Response and Resistant in Psychosis Working Group Guidelines. And these fundamental aspects of guidelines is something which we are all very well aware of it. Just that if you look at the recent treatment guidelines and the definition with respect to the treatment-resistant schizophrenia, there is an emphasis on establishing a prospective treatment resistance at least to one antipsychotic medication, especially if the previous history of antipsychotic treatment is unclear. So that is number one. Number two is optionally, one can consider uh, giving a trial with long-acting injectable. So that is something which has been introduced as it is more like an optimal requirement in defining treatment resistance. Now, before we decide about treatment resistant, there are certain related clinical concepts that we need to carefully review. One is called as pseudo-resistant schizophrenia. Pseudo-resistant schizophrenia indicates a condition where the patient's clinical profile appears treatment resistant, but the primary driving reason could be any of these. For instance, it could be non-adherence, concomitant substance use. There could be coexistent medical disorders or other medication that may affect antipsychotic pharmacokinetics or pharmacodynamics. And of course, there is a role for adverse and detrimental psychosocial condition. And importantly, lot and lot of recent studies are coming up towards this concept of dopamine supersensitivity psychosis, which to an extent is a re-emerging interest. The second important concept we need to consider in the context of treatment resistance is treatment resistance versus resistance to treatment. The first point I emphasized was pseudo-resistant. The second point I'm highlighting is resistant to treatment. Uh, Resistant to treatment indicates people that though they have received enough medications, their plasma levels do not show adequate amount of antipsychotics. For instance, in a study that was published from a Clozapine clinic, when they looked at the patients that were referred, this data summarizes of 36 patients. In them, 16, that is 44% had subtherapeutic plasma antipsychotic level. So this is something which we may have to kind of think through and look at reasons why a person may have poor bioavailability that may present as treatment resistance. A subtherapeutic plasma level could be due to non-adherence, poor absorption, and rapid metabolism. Especially in the early treatment phase, if there is a poor clinical response, there is a potential role for plasma level monitoring of antipsychotic. And this is something which is coming up. As of now, the cost benefits of the plasma level monitoring for antipsychotics other than clozapine is not certain. But with more and more research in this area, this is one particular component of assessment which is likely to become more critical. Now, coming to the summary of the clozapine status, more and more robust evidence supports the superior efficacy of clozapine in schizophrenia. So we can look at several important meta-analyses that have appeared over the past decade or so, which has kind of reiterated the superiority of clozapine in treatment-resistant schizophrenia. So this is something which is a very well-established finding in schizophrenia literature. Now, when we look at clozapine, there are certain predictors which may aid us to look for a good response, especially this shorter duration of illness, higher baseline clinical symptoms, high functioning individuals, and coexisting affective symptoms. And there are certain specific clinical factors which will perhaps make us to prefer clozapine, especially if there is a high risk for suicide, persistent severe aggression, greater risk for extrapyramidal side effects, severe polydipsia, and there is recent literature to suggest if there is a coexistent cannabis influence on the psychosis. This is a relatively common comorbidity that we come across, especially with the cannabis and other kinds of substance getting more and more available with recent times. So if there is a cannabis dependence which has complicated the course of schizophrenia and presenting with non-responding symptoms, the role for clozapine may be better. So there is very few recent literature which is suggesting this important clinical lead. Now, having seen several literature support that clozapine is something which is distinctly superior, especially in treatment-resistant schizophrenia, how can we optimize the clinical utility of clozapine? One important factor that is emphasized again and again is that the earlier we initiate the clozapine, the better will be the response, because delay in initiating clozapine is a major factor which impedes good response, and the longer the delay, the poorer was the response. In a clinical data that looked at what is the duration beyond which the clozapine doesn't seem to work that better in people with treatment resistance, it was shown that 2.8 years was the best predictive cutoff value of a delay in initiating clozapine. This means that the earlier we initiate the clozapine, the better will be the outcome. With respect to this aspect, we have been running clozapine focused clinical program at NIMHANS. My colleague Dr. Vijay leads this program, where they have looked at what is the recommended clozapine dose to achieve therapeutic serum level in Indian scenario. So this is something which we have been looking at in the recent time, and now we have established clozapine assay services at NIMHANS. So this is one of the first publication that has come out of this data. In that, what was documented is that the clozapine dose required for therapeutic serum clozapine in Indian population was as less as 140 milligram. So this is something which is very different from what has been reported from the Caucasian population, which is much higher than, like, nearly twice that of what was found to be adequate in Indian patients. Coming to the last part of my presentation, I just want to emphasize on one of the neuromodulation technique that is getting more and more attention in the treatment of especially the persistent symptoms in schizophrenia, more specifically hallucinations and related positive symptoms. That is transcranial direct current stimulation, which is based on the principle that weak direct current can modulate neuroplasticity. So TDCS, which is the acronym for transcranial direct current stimulation, is a non-invasive, safe technique that involves the application of low intensity direct current using bioconducting electrodes that are placed on the scalp. And this is the protocol that we follow for treating hallucinations in schizophrenia, with the anode placed on the scalp corresponding to the left dorsolateral prefrontal cortex and the cathode over the left temporoparietal junction corresponding scalp. And the duration of the protocol is 20 minutes of stimulation, which is given twice daily with an intersession interval of 3 hours. The more recent updates of this protocol, we have been using twice daily session with a gap of 20 minutes in between. That means every day's TDCH sessions will get over in 1 hour's time, versus what used to happen earlier was about 4 to 5 hours time. So this was the randomized control trial efficacy data that we published a few years before to support the benefit of add-on transcranial direct current stimulation in people with persistent auditory hallucination. This is the work which was a PhD thesis done by my colleague, Dr. Anushri, and helped by Dr. Shiv. And more recent advances have kind of led us to use what is called as a high definition transcranial direct current stimulation. This is a work which is done by Dr. Sriraj. Compared to the conventional TDCS, the high definition TDCS helps us to modulate the brain in a much more focused way. And very recently, especially after COVID, we have been using what is called as an accelerated transcranial direct current stimulation protocol, in which the 10 sessions of TDCS were given in 2 days' time, that is 5 sessions per day. And we are finding this kind of accelerated TDCS protocol to be well tolerated and is also giving comparable clinical benefit. These initially we have been publishing only case series related to accelerated TDCS. There is sham controlled study which is going on now. Dr. Anushri is conducting that study. But the summary point is some of these neuromodulatory interventions can be given in a much more accelerated way so that the entire treatment could be completed within 2 days' time. So that is one of the recent advances that is happening with respect to the neuromodulatory intervention in schizophrenia. So yet another advance that is coming up is with respect to transcranial direct current stimulation. This is something which can be implemented as a home-based neuromodulatory intervention, especially in certain patients who need continued neuromodulatory sessions with the TDCS. So we have initiated some pilot studies in this area, and we have evolved a protocol which is basically coordinated by colleagues here, Harsh, Sriraj, Shivkumar, and Dr. Suhas. So in this particular home-based TDCS protocol, we carefully choose patients and caregivers who are amenable to be trained, and where we will also be able to monitor remotely and give a TDCS and a home-based approach. So this is something which is coming up in treating some of the persisting symptoms in schizophrenia. Our experience in this area has been predominantly in auditory hallucination. We are in the process of expanding this very carefully. And to this effort, and also looking at some of the other neurobiological advances, we have been conducting multi-centric studies. Professor Jagdisha, Dr. Urvaksh, and colleagues from both Central Institute of Psychiatry, Ranchi, Dr. Nishant, and KMC Manipal, Dr. Samir are part of this kind of multi-centric program. So with this, I will like to summarize in terms of if we are looking at the treatment for schizophrenia, individualized antipsychotic choice is something which is very important. One of the recent shift in the guidelines is that we need not wait for much longer time. If there is no improvement at all at the end of 2 to 3 weeks, it is worth considering another antipsychotic. And also there is an increased emphasis on the role of long-acting injectables, even in people that are otherwise adherent. So this is something which is again coming up as a recent recommendation. And with respect to Clozapine, the earlier we initiate, the better the outcome. And of course, we have to look at several factors that are associated with the treatment resistance, which could be a pseudo resistant or resistant to treatment and things of that sort. And these are essentially the guidelines that are summarized as per my previous slides. So some of the other points I try to emphasize are dopamine supersensitivity psychosis, the significance of plasma monitoring, and need to reduce the Clozapine below 3 years of resistant symptoms. And I briefly touched upon the role of add-on TDCS. So with this, I will stop, and I wish to thank my teacher, Professor Gangadhar, as well as several of my colleagues who work with the team in the INSTAR program, and also a lot of students that do all this research work, and several of my collaborators that made these works possible. And with this, I'll stop here. Thank you again for this invite and opportunity.
Thank you, Dr. Venkat Subramanian.
Yes, sir. Yes, sir. Thank you.
Yeah. Many clinical dilemmas for the practitioners. They are now cleared with your presentation, especially Clozapine and things like that. And the recent advance is transcranial direct current stimulus. This is one of the, especially for schizophrenia, hallucinations in schizophrenia. Now the topic is open for discussion. Request the participants to interact with Dr. Subramanian.
Sir, I'm Dr. Raman Rao.
Yes, sir.
Sir, in your experience, did you come across any severe hepatotoxicity with clozapine, sir?
No, no. Yeah, but this is a clinically significant question, sir. I'm glad that you touched upon this. Yeah. So if we look at the newer antipsychotics, one of the underexplored adverse effect is the hepatotoxicity or harmful effect on the liver. More than frank hepatotoxicity, what is being documented in research is the fatty liver changes. So that is something which is reported with especially the newer antipsychotic that also have the tendency to increase the weight. So this is something which is worth exploring and considering in our clinical practice. In patients where I have identified a fatty liver, one of the clinical intervention that I have found useful is add-on folic acid. Adding folic acid, and of course at the time, showing the adverse effect on the liver, which is partly due to the antipsychotic and partly it could be due to the coexisting metabolic status, especially the obesity and things of that sort. So this the folate helps to protect further problems, protect from further problems due to fatty liver, and also it gives us an opportunity to encourage them to get into adaptive lifestyle. Thank you. Thank you for the questions. But frank hepatotoxicity with clozapine, I have not come across in my experience.
Yes. Just recently today, only one patient who is on treatment with clozapine for so many years. Somehow she developed jaundice, and the gastroenterologist felt that possible she has gone up 20 milligrams bilirubin. They have attributed that to the clozapine, and of course they have stopped it, and later they have introduced some other medications. But I never saw any patient in my own clinical experience who developed any jaundice with the clozapine. So I would like to share this information with you.
Right. So that's an interesting experience, sir. Was this patient re-challenged with the clozapine?
No, we don't want to re-challenge because in the private practice there is a problem. Yeah, in fact, she needs clozapine because she developed a tardive dyskinesia and other problems. So that's why we have shifted to clozapine, schizoaffective disorder. Sir, regarding this high definition TDCS, what is the cost of it, and any comparative studies with RTMS
Um,
in refractory hallucinations?
Right. So the cost of high definition TDCS is somewhere in the range between 15 to 20 lakhs is the cost. There are actually no head-on studies which have compared high definition with RTMS. We are in the process of conducting a study where we are comparing the conventional TDCS with the theta burst stimulation. So that is ongoing. Apart from this ongoing study that we are doing, I am not aware of any study that has compared TDCS and TMS as a head-to-head design in schizophrenia.
Thank you. Thank you.
Thank you, sir.
Sir, I'm Dr. Uday Kumar, sir.
Yes, sir.
Am I audible? Sir, awesome presentation. Thank you. Sir, my doubt is maybe a comment, maybe we've been chronic or resistant to the drug, and then think of Clozapine. And now, shorter duration of illness being one of the best predictor to respond to Clozapine, should we start and see in early stages of schizophrenia, sir? Is that you mean to say?
Yeah, that's clinically very important question. Yes, when we look at the literature, if the evidence suggests the earlier we start Clozapine, the better is the outcome. Why not start it as amongst the first line agent? So there are few trials that I've looked at. For instance, first episode untreated patient were randomized to say Clozapine versus chlorpromazine. These were done many years before. So when they examined in such a situation, the differential superiority of Clozapine was not found. In the sense, Clozapine was found to be as effective as the comparator antipsychotic. So this finding was replicated in few more studies later. Based on these observation, there are two recommendations. Number one, given that in patients who have not been treated or who have not shown failure to do antipsychotic, given that Clozapine efficacy is comparable to another antipsychotic in that population, whereas the risk with Clozapine is definitely more with respect to some of the idiosyncratic life-threatening side effect. Clozapine is not recommended. The second clinical learning from that is perhaps people that do not respond to other antipsychotics, antipsychotics other than Clozapine, it is likely their neurobiological profile might be different. Perhaps these people are selectively predisposed to respond to Clozapine. The challenge is, as of now, we do not have a reliable investigation through which we can, confidently predict who will respond to Clozapine and who will not. So till we reach such a stage, I think we need to look at least two adequate antipsychotic trial and then go for Clozapine. Even if we go for 3 antipsychotic trial, we would still be able to initiate Clozapine much sooner than the 3 years of treatment resistance. Actually, if you look at the data, it is not the 3 year of duration of symptom, it is 3 years of 3 years once the treatment resistance is established. So there is actually quite a bit of window which we can utilize, to optimize the benefits with Clozapine, sir. But this is a very important question. One other point I want to add is very recently there is some evidence which is suggesting perhaps we can even look at going for Clozapine as the second line agent rather than the third line agent. So this is something which is upcoming. In my experience, I have used Clozapine very rarely as a second line antipsychotic, especially in patients who have not shown any response at all to the first medication. So usually it will be either risperidone or olanzapine or amisulpride, but they will also have significant aggression and a risk for suicide. So in very carefully selected and where with an informed consent, in such patients, I have found Clozapine to kind of give a very good impact. But so the summary is, I would probably not use Clozapine as a first line agent. I would prefer to use it as the third molecule, except for in a very carefully selected population, I may consider it as a second line agent.
So with your permission, I would like to read out the questions in the chat box. So,
Yes, sir.
Dr.
Yes, sir.
Bharti, is there any difference between treatment resistant and refractory schizophrenia? Is it same as clozapine resistant schizophrenia?
Okay, okay. Yeah, I think there are different terminologies that are being used. The standard terminology is the treatment-resistant schizophrenia. Now, refractory schizophrenia generally refers to treatment-resistant schizophrenia. On the other hand, clozapine-resistant schizophrenia is also called as ultra-resistant schizophrenia.
So, one more question, sir. Options available for clozapine resistant schizophrenia?
Right, right. So, if you look at clozapine resistant schizophrenia, in those patients, the best available evidence is to use ECT, electroconvulsive therapy, in the especially the acute phase of treatment. And in case if they show very good improvement, there is a role for maintenance ECT. So this is with respect to the evidence level. On the other hand, if you look at add-on antipsychotics, there is a role for amisulpride, aripiprazole, and lamotrigine, valproate. So these are the add-on molecules which we can consider in clozapine-resistant schizophrenia if you are looking at alternative pharmacological action. And of course, when we are looking at clozapine-resistant schizophrenia, it would be useful to ensure that the patient is having adequate bioavailability. So this is the context in which the need for clozapine assay is gradually picking up. I think in times to come, we will get this investigation much more affordable than now. And the third option which may be considered is the role for add-on neuromodulatory interventions like transcranial direct current stimulation or transcranial magnetic stimulation.
Yes. So next, I like to club the two questions. Recent advances in the treatment of negative symptoms of schizophrenia and the role of L-carnitine in
Yes.
negative symptoms.
So yeah, with respect to L-carnitine, there are several molecules like L-carnitine, N-acetylcysteine, omega-3 fatty acids. So there are so many adjuvant molecules that are reported in case series level or some case report level. Anecdotally, we would have found some people to respond better, but there is no consistent evidence to suggest that these one could be tried above the other. With respect to the general treatment recommendation, the role for amisulpride as well as add-on SSRIs is something which has some evidence. One interesting report that we have come across, especially from colleagues in our institute, both Dr. Gangadhar as well as Dr. Shivarama, they have done work on the role of add-on yoga-based therapy, initially as an EMANS-based study and later as a multi-center study to showing that in negative symptoms, there is a role for interventions like yoga. So essentially, the approach will be to remove possible secondary causes or causes that lead to secondary negative symptoms. That is number one. The second is looking at optimizing the antipsychotic treatment. Either we can look at something like amisulpride or adding SSRI, and concurrently looking at some of the lifestyle-based interventions like yoga. And in patients, we can try any of the other molecules. So there are some reports of add-on vitamin B12 or vitamin D, especially if it is deficient, can help in negative symptoms. Whereas with respect to some of these molecules like L-carnitine, we need more research.
So in a child of 10 years with family history of schizophrenia, when there are some prodromal symptoms, what would be the best line of management?
Yeah, this is a challenging clinical situation. At one level, we know that there is a family history of schizophrenia. At the other level, we have a very young child. The consensus is, unless otherwise there are definitive psychosis symptoms, especially positive symptoms, in a age group of 10 year, the role for antipsychotic is not recommended. So in such situation, the approach is careful observation and look at any other factor that may be contributing to the prodromal symptoms. So it could be related to some other psychosocial stressor or some other emotional difficulties which the child may be facing. On the other hand, if the child starts developing, definitive psychosis symptoms, or in certain situation where there is a very heavy family loading of schizophrenia, and we see a distinct deterioration of the child's function, especially the academic and the social interaction, which is declining gradually over a period of at least few months, we see continued decline. That is one instance where even in the absence of frank positive symptoms, we may consider initiating antipsychotics. In such a situation, in my experience, I have been working with the child psychiatry team here at NIMHANS. We see children, but not in this kind of profile of a prodrome. Most of them are children that have already developed a schizophrenia. There is a role for medications like aripiprazole, especially in the child and adolescent. The partial dopamine agonists may be the preferred molecule to begin with. So the summary of these discussion points is, unless otherwise there are very definitive positive symptoms, the role for antipsychotic has to be carefully reconsidered. Unless otherwise there is a persisting deterioration in the context of heavy loading of family history of schizophrenia, which is also called as genetic deterioration syndrome, or the presence of blips or brief lasting psychotic symptoms or acute psychosis, that is the situation in which we have to consider antipsychotics.
So one last question we'll take, sir.
I think
Insights on depot preparations in case of clozapine resistant schizophrenia, second generation versus first generation depot.
Right. Okay. Yeah. Now, if you look at the depot injections, we need actually more systematic studies on first generation versus second generation. But in clozapine resistant schizophrenia, the advantage of second generation medications is mainly because of the formulation with which they have been made available. Since they are aqueous solution based formulation, the tolerance is better, number one. Number two, the first generation antipsychotics carry a higher risk for tardive dyskinesia. That is where the newer depot score a plus. There are studies, especially from Japan, that have shown in clozapine resistant schizophrenia, long-acting depot of paliperidone has found to be helpful. So this is where the current evidence is. And there is also a question on prodrome. Is there a role for antidepressants? Yes, there is a role for antidepressants. Studies have shown if the prodrome presents with depression, use of antidepressants have been helpful, and there is some evidence to suggest it may even avoid conversion to psychosis. So yes, antidepressant is something which is worth considering if the prodrome presents with depressive symptoms. So both antidepressant, there is also a role for short-term treatment with benzodiazepines.
Yes. And one more last is the neuromodulation in negative symptoms.
Yes, so that is something which is upcoming, especially the role of both transcranial magnetic stimulation as well as transcranial direct current stimulation targeting the dorsolateral prefrontal cortex is worth considering if it is available in the therapeutic setting. So, but we need more research in this area. There are I could think of few randomized control trials with mixed findings. So essentially, this points towards the heterogeneity of the negative symptoms, but add-on neuromodulatory intervention is worth considering. Thank you.
So there are no more questions. Now I hand over proceedings to Dr. IVL sir for his
Sir,
closing
thank you,
remarks.
Dr. Venkat. It's a wonderful lecture, and is almost we are in the class of NIMHANS. Thank you. Thanks a lot. And now I hand over the proceedings to the organizers.
So now over to Dr. Sharath for vote of thanks.
Good evening, all. At the outset, I would like to sincerely thank Dr. G. Venkat Subramanian sir for his acceptance and delivering an excellent and informative talk. I sincerely thank today's chairperson, Dr. IVL sir, for chairing this session smoothly. I thank all the members who have participated in making this webinar successful, even we have initial technical glitches. I also extend my sincere thanks to East West Pharma for their technical support. Before I conclude this webinar, this will be our last academic event of this IPS AP State Branch Office during our tenure. I sincerely thank our President, Dr. GVS Murthy sir, Dr. P. Lokesh sir, and immediate President, Dr. IVL sir, for making this happen. Good evening, all. Good night, all. Thank you.
Thank you, Dr. Venkat Subramaniam,
Thank you, sir. Thank you very much.
for invitation. Thank you. It's a very nice and very insightful and lecture. We are very happy to hear your talk on schizophrenia. Thank you. Thank you.
Thank you, sir.
Thank you. Thank you.